All right, so we're doing GI now. I think I might actually be Unit 8, so I'll have to update that. But first thing we're going to be covering is going to be GERD, otherwise known as? Yes, gastroesophageal reflux disease. What is that? What does that mean? Yes, you're having reflux of gastric acid. What's LES tone? That's my favorite band. What is that?
The lower esophageal sphincter.
Yep.
Regurgitation.
Absolutely. Perfect. So that's specifically what it is. So basically we're going to say it's the chronic symptoms or the mucosal damage that's produced by this abnormal reflux of gastric contents into the esophagus. And we're going to see we have lots of medications that can be used to help limit this. Also lots of medications that can cause this as well, which we'll talk about. So again, just a few definitions. So you can have reflux esophagitis, which is just inflammation of the esophagus that happens from this reflux. You can have erosive esophagitis, which is obviously a more severe form. You're actually having kind of chronic erosion of the esophagus. And you can even have this very severe case called Barrett's esophagitis, where you're basically having actual cell type changes that can occur. And kind of what does this put you at risk for? Cancer, yeah, esophageal cancer is the big bad thing you're really worried about. So we know that's going to occur in all age groups to varying degrees. So again, you'll see it increase in adults greater than 40 years of age. Tends to be pretty equal between genders. And certainly you'll see lots of pregnant women who will suffer from this, around 30 to 50% with heartburn daily. My wife certainly had this quite a bit when she was pregnant. And then this Barrett's esophagitis tends to be more skewed towards a male, so around 6 to 1 as far as that ratio goes with that. Certainly, you're going to see that while a lot of people do have heartburn weekly, or at least complain of those symptoms weekly, that we're going to have a lot of frequent use of some over-the-counter medications for this. So you can guys think of any over-the-counter medications that you can treat GERD with? Zantac. We'll look at some H2 blockers. What else?
Ranitidine, Zantac.
Prilosec. I'm sorry. Ranitidine is Zantac. Yep. So we'll look at those. Yep. So Nexium. So that's esomeprazole. So those are proton pump inhibitors. And then you mentioned Mylanta. What is that?
Magnesium.
Yeah, so it's magnesium hydroxide, aluminum hydroxide. You have calcium carbonate. So there's antacids as well. So those are the main kind of players that we'll see being used. And again, the PPIs, or the proton pump inhibitors, are some of the more recent ones to have gone over the counter. Many of those are still prescription only. So again, we know this is retrograde movement of acid from the stomach into the esophagus, but you're also having lots of other proteins and things like bile acids, pancreatic enzymes, pepsin that are getting up there. And so by increasing the contact time of the stomach acid to the esophageal mucosa, you kind of have this imbalance between more the aggressive and the defensive factors that are at play there. So again, your stomach is nice and well coated generally in order to help prevent stomach acids from eating through that. The esophagus really shouldn't have to have as much of a defense, because normally the gastric acid shouldn't be hanging out there too often. So like you mentioned, low LES tone, or that lower esophageal tone, can sometimes be an issue here. You can have issues of increase in intra-abdominal pressure. So again, if you go try to work out or go swimming too early after you eat, you can see that. Just anatomic factors, kids can be a big issue with GERD if they have kind of dysfunctional anatomy that's leading them to have more reflux. Lots of other reasons, gastric emptying, composition of the refluxate, or kind of what they're actually refluxing can also influence this as well. Just a picture of kind of what you would see with the atonic lower esophageal sphincter. Has kind of free flow of the bile acids up that direction. Okay, so what are we looking at here besides a big mess, right? So essentially what we're going to be looking at here are going to be some of the cells that are in the gastric lining of the stomach, and we'll see where a lot of our gastric acid is really coming from and what some of those factors are. So I'm going to try to pull out my laser pointer here if I can. There we go. Okay. Ooh, getting fancy now. So one of the big cells that are involved with this are going to be our parietal cells, and so these are really going to be important for secretion of gastric acid. You can see here this kind of counter transport, this hydrogen potassium ATPase pump. It's that active pump that's going to help to secrete hydrogen ions and produce that very acidic environment that's within the stomach. So what are the things that are influencing this? What are the things that are trying to kick out more gastric acid? Well, lots of things. So for sure, we can have things like histamine, specifically affecting those H2 receptors. So we'll see H2 blockers being a big way to inhibit this. We're going to have also muscarinic receptors being involved in this as well. So that's that M3 type receptor, where acetylcholine is directly activating those receptors to increase activity of that proton pump. Why do you think the muscarinic receptors are involved, or why do you think that can have an effect on gastric acid secretion? Yeah, so it's parasympathetic. And think about which is more activated after you eat. Yeah, you should be your parasympathetic. So you imagine after you eat, you're kind of like, I'm just kind of tired. I'm just going to digest for a while. Those muscarinic receptors are being activated a lot to increase gastric acid secretion. You will see that things like prostaglandins are going to be useful for inhibiting this process. This will have an inhibitory factor. So what kind of drugs would be affecting this? NSAIDs, absolutely. So this is where we see a lot of the gastric ulcers that come about from NSAID use, because you're inhibiting the production of these prostaglandins. So you're going to have more activity of those proton pumps, right? You'll also see an enzyme called gastrin, which will help to secrete more gastric acid. You'll have some of these paracrine cells, which are also going to be releasing more histamine from these cells, and these are also going to be affected by your muscarinic receptors and your gastrin receptors. So just to see, there's a lot of different sites where drugs can be working specifically to inhibit this process of gastric acid secretion. And where do you think the antacids are working at specifically? Think they're working intracellularly, more on the out in the stomach? Do you think they're working more on the blood side? Yeah, they're working basically in the stomach itself, right? Because they're going to be working to neutralize the acids that are being kicked out there, right? So just remember kind of where the different sites are working. More, the histamine more working kind of on the kind of luminal side of those cells versus where the proton pump inhibitor is working, and different things like that. So we'll go over those in more detail. Yes.
Which side would be the luminal side?
So this would be basically the inside of the stomach, right? This is where you're kind of kicking out the acid to, and this would be basically the kind of the more where the blood's at, right? All right. So moving on. Also, what we can see is that you have these epithelial cells which are responsible for kind of protecting the stomach, and so here you're going to see that prostaglandins will have a positive effect on this, and you're going to have muscarinic receptors having another positive effect here in order to increase release of bicarbonate and also mucus. That's a kind of misspelling of mucus, but that's okay. And so essentially what you end up finding is that you have this nice mucus layer right along these epithelial cells that retains a pH of 7. And then in the gastric lumen itself, it can be much more severe pH, like 2, right? So again, pH is much, much lower there. But by having this mucus layer, you kind of protect things and prevent gastric ulcers from being produced, right? Okay, so some risk factors for GERD are going to include certainly some physical ones like obesity, delayed gastric emptying, pregnancy, hiatal hernias, and recumbency. So kind of lounging around, leaning back, and then obviously some behavioral things as well. So alcohol use and smoking, consuming large meals. So of course, when I go to Texas de Brazil and I make use of the green side of the card pretty liberally, I have some issues with this, along with some pretty bad meat sweats, but that's okay. We'll see that certain medications are also going to influence this, and then eating certain types of food. So what type of foods do you think will? Spicy, yeah. So if you go for the super spicy curry, you're going to be having some issues potentially.
Some people say milk and dairy gives them this?
Yep, so I don't see that very frequently, but certainly some people are going to have different triggers for that. Yeah. Okay, so some of the things that may worsen GERD symptoms, we already kind of mentioned the alcohol, we mentioned spicy foods, but certainly some more acidic products, things like citrus or tomato products. We mentioned fried and fatty foods can do this, chocolate, peppermint, basically all the good things in life can potentially give you heartburn, right? And then on the medication side, so things that are inhibiting the ability to produce that nice gastric barrier, so things like anticholinergics can do this, but anything that can slow down the GI tract. So for instance, we see narcotics like opioid analgesics. They can help slow down the GI tract, so you kind of slow the transit time down so you can have more time to reflux things from the stomach. We mentioned calcium channel blockers very frequently cause constipation, so that would make sense. Really anything affecting that smooth muscle and preventing it from really causing the normal transit you would see. So nitrates can do this. Bisphosphonates are another big one. Does anyone know what a bisphosphonate is? Where you might use it? It's actually for osteoporosis. So if you ever see like your Bonivas and things like that, those are your bisphosphonates. Those have a real big tendency to stick in the throat and can lead to some GERD-like symptoms. So that's another big one. Potassium iron salts, aspirin, and NSAIDs, obviously that's going to be more due to inhibiting the prostaglandin synthesis and whatnot that can cause some issues. So lots of different medications that can be involved in this. So if you have a patient who has GERD symptoms, it's important to do a good medication history to find out what they're taking, which could be influencing this. So we know the complications. You can see issues of esophagitis, strictures that can form. Sometimes you can have patients develop anemia due to this kind of chronic low-grade esophageal bleeding, and then you worry about Barrett's esophagus and also cancer risks and things on the chronic side. So again, heartburn or pyrosis is going to be this hallmark symptom, but certainly belching, regurgitation, water brash, or this hypersalivation can occur as well. All right, some atypical presentations you may see with GERD can include things like pharyngitis, chronic cough, hoarseness. So just be aware there's some other things that can be going on that can be also signs of GERD. And then obviously there are some warning signs. So if they're developing any of these symptoms, these are automatic things that they should be warned to come into the ER for. So they're having like really bad continual pain, difficulty swallowing, pain upon swallowing, unexpected weight loss, GI bleeding, which of course if it's going to be more related to GERD or esophagitis, how should that GI bleeding be witnessed?
Bright red.
So bright red from where? Okay, sure, from coughing, or what else could you see? Yeah, so black tarry stools from basically from the blood being broken down by the gastric tract, right? So again, it could be bright red coming from the top, or it could be dark tarry coming from the bottom.
Without the coffee ground resistance.
That could be more if you were to actually have like a gastric ulcer where the blood itself was actually being metabolized there, right? So if it's coming more from just the esophagus, if you're just having like local bleeding there, it'd probably be more bright red, but the coffee ground can be more actually like a gastric ulcer that's perfed or something. Yeah. Okay. So again, there's no good gold standard for diagnosing GERD. Usually it's going to be based on clinical history. So nothing super invasive needs to be done. Certainly you can do things like endoscopies. You can do ambulatory esophageal pHs. You can test for that. So lots of different ways if you had patients who had maybe complicated, refractory, or atypical presentations. But very frequently you're just going to go off the symptomatology and be able to base your treatment off that. So goals, we would like to alleviate and eliminate symptoms if possible. We want to decrease the number and duration of episodes. We'd like to be able to give the injured mucosa a chance to heal if we can. So that's where we're going to see a lot of the medication we use when we talk about H. pylori and ulcers for treatment of that, and prevent any complications from occurring in the long run. Obviously, you would like to have them do their lifestyle modifications, so they smoke and drink and all those other things that can aggravate it. Tell them not to go to Texas Day Brazil quite as often. That might help. And again, then after that point, we can start to look at more pharmacologic interventions and then potentially even interventional therapy. So certainly, with a lot of our kids who come in with really bad reflux, you can have these Nissen fundoplications, I think is the term. I always hear them referred to as Nissens, but basically it's a surgery where you can kind of like pull some of the stomach muscle up over the lower esophageal sphincter, and it helps with the closing of it. So it's a pretty common surgery. You'll see some kids get that really bad reflux. Obviously, if they can do some lifestyle modifications like weight loss, elevate the head of the bed, dietary changes, smoking cessation, those are all good things to do that can help with this. Okay, so the options that we'll look at for treatments of GERD, we're going to look at antacids. There's going to be another one called Alginic Acid. We'll look at it as well. We'll look at our H2 receptor antagonists, proton pump inhibitors. For patients who have impaired gastric emptying or slowed, say gastroparesis, prokinetics we'll be looking at, and then also some mucosal protectants. So basically, when you're looking at these different treatments, they're going to be doing kind of one of several things. So one, they could be neutralizing the excess acid. They'll be reducing gastric acid secretion, or they'll be enhancing gastric mucus defense. So it's important to remember which drugs are going to be working through which mechanisms, because one, if you're going to be looking for synergy between different drugs, you obviously don't want to use drugs that have the same mechanism. You might want to try ones from different areas in order to help you try to get some synergistic effects there. So we'll look at the different ways these are working and how you can potentially combine them or ones to avoid. Okay, so things that will help to neutralize the excess acid, these will obviously be our antacids. That would make sense, right? So they're going to be working to directly neutralize acid in the stomach itself. So when do you think these would be most effective to take time-wise?
Before eating?
Yeah, right before you eat, right? Or maybe after you eat if you're already having some of the symptoms. Because then again, that's when you're producing the most acid, right? So that's a good idea to start taking them then. Again, we're going to see that there are going to be some therapeutic differences in the different preparations. So some of them will have different neutralizing capacities, some will have different solubilities, some will have different palatabilities. So some patients might respond to one better versus another, especially from the palatability side. So here are the different ones we could potentially use. So we have sodium bicarbonate. Again, when that combines with HCl or hydrochloric acid, it's going to get turned into sodium chloride, salt, basically, water and CO2. Because you're producing more CO2, what do you think is a potential side effect from this? Maybe not acidosis so much. Hopefully not. What else could you see? You're producing more gas in the stomach. Burp. Yeah, so retching you can potentially see. So think about that. Calcium carbonate is going to be another one. So you can see where that forms calcium chloride when it combines with the acid. You'll have aluminum hydroxide, and then you'll have magnesium hydroxide. Those are going to be some of the main ones you're going to see being used for antacids. So sodium bicarbonate, otherwise known as baking soda, it very quickly neutralizes the acid and produces sodium in this alkali load. So here you can be seeing certainly some gas production that can occur. You can see some fluid retention potentially because you're adding more sodium for those patients. So again, if they're already kind of salt sensitive or have salt overload, this could be a potential cause for more fluid retention. And then you can also see because with a lot of these antacids, they're changing the gastric pH of the stomach. They're raising it, right, because they're making it more alkalotic. That's going to tell your stomach, hey, I need to produce more acid. So you actually can end up seeing more gastrin release occurring there. So that's trying to kind of battle. They're kind of at odds with one another because as soon as you raise the pH, the stomach wants to spit out more acid, and so then you may need more antacid in order to help kind of counterbalance that, right? So there's kind of a limit to how much these are going to work as far as neutralizing agents go. At some point you're going to need something a little bit stronger for more severe cases. Yes.
How do you take this?
How do you take them? Orally.
But like, what form? Like.
So most of them are going to come in tablets. You'll find. Yeah, so like Tums, some of them will have chewable products. No, so sodium bicarbonate, you can find sodium bicarbonate tablets that you can take. Or you can just take baking soda and just.
No,
you could. Why not?
That's what I'm visualizing.
It's just sodium bicarbonate. You put it in your food, right?
It's fine to do.
Yeah. Just don't do too much of it. Yeah. So this one doesn't get used too frequently, but just know that it's out there. It's available. Sometimes we'll have kids who have kind of chronic acidotic issues. Sometimes we'll give them sodium bicarbonate as a means to help kind of counterbalance that a little bit. So you'll see that most often. But as an antacid you'll use for actual GERD, this is probably one of the least common ones. But is certainly a home remedy. Someone can take some baking soda and can get some relief from that. So if grandma's cooking is a little too much for you, you can just go to the back of the fridge and pop some out. The next one we'll have is going to be much more common. So this is our Tums, or our calcium carbonate. This is nice because it works very rapidly, helps to have pretty moderate neutralizing capability. And keep in mind that you're also going to absorb some of this calcium. So if you have a patient who already has, say, kidney issues and they already have too much calcium on board, this could potentially exacerbate that. Or if they have issues with kidney stones, this could also be a problem for that as well, right? And then anytime you're giving calcium orally, you always run the risk of having constipation. So you'll see that some of these are going to be more likely to cause diarrhea. Some of these are more likely to cause constipation. So just be aware of the difference there between those. We also have aluminum hydroxide. Another name for this is going to be Amphagel. This one is probably not used for GERD quite so frequently. This is more going to be a really good phosphate binder. So you can see here it actually binds up phosphates that you would get in through your diet with like a lot of meats and things. So this is more frequently used for patients with chronic kidney disease and hyperphosphatemia. So just be aware there's multiple places where you could use this. But you'll see aluminum hydroxide oftentimes in combination with magnesium hydroxide to form things like Mylanta or Malox. So again here, you may see some decreased stomach emptying, which will increase gastric acid secretion. So again, you're always going to have some kind of a self-limited amount of work that these drugs can do because of that. The nice thing with aluminum hydroxide, it kind of forms this nice cytoprotective effect on the mucosa, so it kind of helps with that natural barrier that you'd be producing anyway. And with these ones, they will cause constipation. And although I didn't mention on the calcium chloride side or calcium carbonate, just be aware that these have the ability to chelate other drugs. So very frequently you want to make sure you're separating your antacids from other drugs. Either take the other drugs an hour before or do the other drugs 2 to 4 hours afterwards, right? So can you guys think of any medications that we've bound up this way? Potentially bile acid sequestrants, maybe. What other antibiotics are a big one? Just for pneumonias.
The cycles.
No, your fluoroquinolones are your big ones. So fluoroquinolones like levofloxacin, ciprofloxacin, those can get bound up by aluminum, calcium very easily. So you want to make sure you're separating those out. This is the time frames. And then aluminum hydroxide is contraindicated in appendicitis. There's been some cases where it's actually is worse than that for some patients. Okay, then you'll have magnesium hydroxide, otherwise known as milk of magnesia. This one has very good neutralizing ability. You'll see that magnesium chloride has pretty low solubility, so you may get a little bit of magnesium absorption through the GI tract, but probably not a whole lot. And you'll notice that this one can cause diarrhea. So has anyone ever experienced milk of magnesia? I've never seen it used. What do you normally use it for?
I use it for like practice lessons.
Not necessarily in this case, but I heard constipation, right? So you can use some of this stuff. Some people call it the green rocket. As soon as you take some, you're going to be like a rocket to the bathroom. So it's very good at causing diarrhea. And so oftentimes you'll see that this is mixed with aluminum hydroxide because that one can cause constipation. So they kind of balance each other out a little bit. So that's why you oftentimes see that combination with Mylanta, Maalox, and whatnot. Now this one, you want to be careful with patients who have either intestinal obstructions, appendicitis, and also renal failure. Because again, renal failure side, because if they absorb too much magnesium, hypermagnesemia can cause some issues. So you want to avoid that. Again, this is a very common combination, as I mentioned. Usually comes in a liquid suspension. Otherwise, it's pretty insoluble. But used together, you can actually counteract a little bit of GI motility. But this one tends to be has a nice kind of coating effect on the GI tract, so provides a little bit better kind of neutralization than you see with a lot of other agents. So this is one I see used very, very frequently. Do you ever hear of magic mouthwash? You guys ever heard of that? Yeah. Very frequently, this is one of the base components of it. Very frequently, you also see it combined with diphenhydramine or Benadryl, and then either something like a viscous lidocaine to kind of help with like aphthous ulcers, or you'll see it mixed with carafate. Sucralfate is a generic name. We'll talk about that one a little bit later in this section. So antacids, some of the problems with the drugs are that, especially when patients are self-treating at home, they can potentially mask worsening disease. So again, if they don't really know those warning signs, they just keep taking it, they may not realize that something kind of worse is going on. These are also nice because they're very safe in pregnancy, but you probably want to avoid formulations of sodium bicarb since those patients are a little bit more prone to hypertension. You probably want to avoid giving them too much excess sodium for those patients. And then, like we mentioned, so tetracyclines can potentially be bound up here, iron, and the fluoroquinolines would be the other big one. The other drug product we'll mention in this group is going to be alginic acid. This is going to be reacting with sodium bicarbonate and saliva to help form this kind of nice viscous solution. So this kind of helps provide a nice kind of barrier function along the GI tract and along the stomach. This does require the patient to be upright, otherwise it could potentially reflux this. And while the efficacy is somewhat controversial, you'll see it in a lot of over-the-counter products where you'll see like an antacid plus alginic acid plus sodium bicarb, or Gaviscon is a common brand name for that one. So if you see that out there, that's basically what it's doing. I think that's actually derived from seaweed, if I'm not incorrect. Okay, so advantages. One, they have rapid relief of symptoms. They are relatively inexpensive. Most of them, or all of them, are available over the counter, and they can be used for breakthrough symptoms, right? So you could be on other things for more chronic control of GERD symptoms, but these are nice as a, say you have a spicy food or something like that. This is nice to get kind of breakthrough neutralization there. Disadvantages, because they're not working 24/7, they're not going to be effective for healing, especially if you already have areas of erosion or you're having some ulcers. You need something that's going to be working more around the clock in order to get some healing time there. You can require multiple doses throughout the day. You worry about constipation and or diarrhea, and then the potential for drug interactions. So those are kind of some of the drawbacks for these antacid products. So, and if we don't want to neutralize the excess acid, we can go along and reduce gastric acid secretion. So the way we can do that, first thing is going to be by blocking the H2 receptor. And so we can do H2 receptor antagonist, which will be blocking this directly right here at this H2 receptor, and basically you're going to see decreased acid secretion by blocking that receptor on these parietal cells. So it'll block both basal, nocturnal, and stimulated acid secretion, so it kind of covers you throughout the day, and will reduce the volume and the number of hydrogen ion concentration in the secretions, right? And also can help to reduce some of the pepsin that you're going to be seeing being released as well. And pepsin being one of those kind of digestive proteins you're spitting out into the stomach. So here are the main ones you're going to see in this group. So it's going to be, and again, all of these are over the counter. So you'll see cimetidine, ranitidine, famotidine, and nizatidine. Probably the most common one you're going to see used is going to be ranitidine. most commonly. This one is very frequently used IV as well. Famotidine I've also seen used IV when we have shortages of Zantac. The one you should never use is cimetidine. Never ever recommend cimetidine. We'll talk about why that is in a second. So some of the indications, obviously, if you're having GERD symptoms, but you can also see it used for peptic ulcer disease, Zollinger-Ellison syndrome, which is kind of this big hypersecretory kind of condition that you can use to help kind of relieve some of that. Yes?
Can you say that again? The Zollinger-Ellison syndrome?
Yeah, it's this kind of like hypersecretory where you're just kind of just spitting out way too much stomach acid on a chronic basis, and it can lead to things like erosions and ulcers and whatnot. So this is used. This is, you know, before the proton pump inhibitors came around. These were your go-to drugs to help inhibit that.
And that's of gastric mucus. Is that of mucus or acid?
Of acid. Too much. Too much mucus probably wouldn't be a problem. It may just. I don't think that would really be an issue, or there's any conditions that I know of that do that. Okay, so the H2 receptor antagonists, they are well absorbed from the GI tract, and most of them are going to be excreted into the renal tubules, so you do need to watch for renal dosage adjustment. So it's one of those things that not a lot of people think about as needing renal dose adjustment, but can frequently go unnoticed, especially like, you know, in really sick ICU patients and things like that. You definitely need to watch for your dose adjustments. So big things you can see, these drugs are really, really well tolerated, but rarely can you see some side effects from these. Things you might run into include like some CNS issues like confusion, seizures, but very, very rare, so really not even worth mentioning here. Potentially you can see some thrombocytopenia, some rash and headache, but again, these are all really well tolerated for the most part. So we see that they're effective in around 60% of patients, definitely more effective than antacids. And again, they're going to provide longer coverage throughout the day. And all the agents are going to be equally efficacious and well tolerated. Basically, the big thing you're going to be looking at is selecting based on the pharmacokinetics, so if something needs to be given more or less often, and also looking at the cost of the agents. All of these are going to be more expensive than the antacids, so again, keep that in mind when prescribing for your patients. And these are also nice because they're going to be pregnancy category B. So again, if antacids aren't going to be good for your pregnant patients, these are going to be good alternatives. Dosing, you're typically going to see it given twice a day. A lot of the OTC dosing, though, is already cut in half from the standard lowest prescription dose, and then a lot of the recommendations are only to use it for 14 days. So if you look at that packaging, it'll say, you know, use for 14 days and that's it. And why do you think they put that limited time frame on there? Exactly. Yeah, so if there's something else going on that you probably should be worked up for, like that way if you're been on it for 3 months, like probably something else should be kind of looked at, so you can go see your provider. Yeah. Again, watch out for your decreased renal function patients and elderly patients. You may need to adjust the dose there. And then you can use these to pre-medicate daily, or you can potentially use it as needed, so it depends on but keep in mind that the antacids are going to work a little bit faster than these guys, so if you're going to have them take it as needed, make sure they take it kind of before they eat, right? They'll give it time to kind of work. And then the big reason why you don't use cimetidine, it inhibits CYP3A4. None of the other ones do that, and for some reason they get put this very dangerous drug over the counter, and so if patients are on their statins or whatever happens to be that can interact here, this can be potentially problematic. So avoid cimetidine, use Zantac, use famotidine, use whatever else you got. Okay. Okay. Then the proton pump inhibitors. So these are going to be working specifically to inhibit this proton pump here. So again, by inhibiting this this mechanism, you basically block off all the effects from acetylcholine. You block the histamine effects, gastrin effects. It basically kind of cuts it off right from the very end point of that process here. So they're irreversible inhibitors. So in order for your these parietal cells to start kicking out more acid, you have to produce a new pump in order to do that, right? So it's kind of why they're so effective, because they're kind of suicide inhibitors for these pumps. And again, after 7 days of treatment, you'll end up seeing around 95% inhibition of gastric acid secretion. So pretty well effective at doing this. The ones you'll see here include esomeprazole, which is related chemically to omeprazole. How do you think those two are related? Yeah, so the omeprazole is the chiral compound, and then the esomeprazole is one of the enantiomers of that. So if you would imagine what an equivalent dose would be, just imagine that for omeprazole, if you're using, say, 40 milligrams a day, an equivalent dose of esomeprazole would be how much? Because again, it's the 1/2 of that chiral. Yeah, 20 milligrams, right? So you just basically cut your dose in half. So very frequently you'll have kids who will come in on, or you'll have patients who come in on, say, esomeprazole 20 milligrams a day, but say your formulary has omeprazole because it's cheaper, you can just double the dose and you have the same amount, or same activity there. You also have lansoprazole, pantoprazole, and rabeprazole as well. Some of these are available IV, so they can be used for really severe cases of either gastric bleeding or hypersecretory conditions or whatever it happens to be, but some of these are available IV as well. So patients who are not being controlled by H2 antagonists alone can be used with these. Zollinger-Ellison syndrome would be another one. Again, these are newer agents compared to your H2 blockers, so be aware of that. Severe GERD and then short-term ulcers as well. So you may see some hyperplasia of parietal cells in these experimental animals, so there is some concern for cancer risk, but in people we haven't really seen that issue. The things you do see with the proton pump inhibitors, though, is because they're so effective at increasing the pH of the stomach contents. Normally the stomach acid is so acidic, at pH of 2, that it really prevents a lot of bacteria from propagating, right? What's kind of the one bacteria that likes to live in gastric acid secretions? The H. pylori, right? So that's kind of the one exception, but most of the other bacteria like to, propagate in an area where the pH is a little bit higher, so maybe later on the GI tract. So the thing you worry about here is that by increasing the pH, you can allow these bacteria to start to form, and then you worry about aspiration of that, especially in older patients. So that's one of the things you kind of have to balance with ICU patients who are intubated, is you can actually increase their risk for ventilator-associated pneumonias when giving these PPIs. But they're also in critically stressed states where they're more likely to get gastric ulcers. So you're kind of having to balance a double-edged sword from that standpoint.
How does it affect digestion? Because I'm sure you need it in the stomach, you need the acid. So if you're on these inhibitors, how is digestion?
It doesn't seem to really affect it very much. I think for the most part, people can still digest food appropriately. There's still enough gastric acid being secreted to do that, but you're just kind of inhibiting. We're probably doing too much anyway in general for the food we're actually ingesting. So even though we're inhibiting it very severely, there's still enough to actually do the work that needs to be done. If that makes sense. One of the other things you can see, and I don't know if I mentioned here later on, is that you run the risk of having, by increasing the pH in the stomach, you lower the absorption of calcium, and so there's some risk for patients who, especially a risk for osteoporosis and things like that, not absorbing enough calcium. So as far as pregnancy category goes, pantoprazole, lansoprazole, and rabeprazole are better to choose because those are pregnancy category B. I'm not going to ask you which PPI to give on a test for a pregnant patient. Just know that they're relatively safe for those pregnant patients. But antacids are ultimately going to be the safest since they are, for the most part, absorbed the least. Again, if you're going to administer these, you can do these daily for symptomatic control throughout the day, or you can do it before a meal. So again, 30 minutes beforehand to give it time to really work. These oftentimes come in capsules which have these little tiny beads inside of them. And essentially, these drugs, when they hit the normal stomach acid at pH of 2, they can be destroyed very easily. So what they actually do is they put them in this coating that can survive that low pH. And then by the time it gets to the duodenum, where the pH is higher, that coating will actually dissolve. So it dissolves that coating and allows the drug to be absorbed into the bloodstream. Okay, so by crushing it or chewing it beforehand, you actually break that nice acid protective barrier and allow the drug to be destroyed before it can be absorbed. So it really limits how well it's going to work, right? So PPIs are going to be better than your H2 blockers at healing severe esophagitis and providing symptomatic relief, but they're also going to be more expensive than your H2 blockers. So just keep that in mind as far as cost goes. Again, you can see some potential drug interactions here with things like ketoconazole and itraconazole, increasing concentrations, but clinically you don't really need to worry about dose adjustments too frequently, and just kind of generic adverse effects you can see with these guys. But again, very well tolerated. Okay, I'm actually going to cut it here. I will post the video online and we'll take a look at the test and see if there's going to be any givebacks or anything like that. So I'll put an announcement up when I get those results in. All right, thanks.